also, I think, on your country's jurisdiction, and to be fair, this is not something that is as yet included in, NCCN guidelines, and so it does depend on, what guidelines your country uses. Okay, for me, and I agree with JJ, I think it's not wrong to do it early, if there's the ability to do so, because I think the problem also in sarcomas is that a lot of sarcomas are, as you know, not very systemically sensitive. Right? So even in the first line, doxorubicin-based treatment, you expect responses in, up to 20% of patients. So a good 80% or more will not respond, So for example, if I want to choose between using, doxo-ifos, or doxo-based combination versus gemcitabine-based combinations at the start, do I want to subject this to testing in HUPOP? That's something to consider as well. Yeah. So the answer is, it depends, whether you need to follow guidelines or not. But I think for me, there is no reason not to test. And for me, it's an additional data point that I use to take into consideration and discuss this with my patient.
Yes, it can be done for treatment-naive cancer patients as long as you're able to give us a sample of the tissue. We can run the test, and in terms of the drug selection, it would likely be most of the standard of care of first-line treatments. So what our test can help with is for cancers where there's like multiple lines, multiple first-line, or even neoadjuvant therapies available for such patients. Hopefully, Optim.AI is able to identify what are the better ones or what are the better treatments that the patients may be more sensitive to in the first-line setting.
Absolutely. I think that's even more, even more strongly to be argued for, to be done in a recurrent situation. So most of the time, we actually included this as part of their clinical management anyway, So if it made sense to do a palliative resection, or if it made sense to prevent a catastrophic rupture, for example, or if there was local recurrence of a very sort of, long time frame for which it does make sense, to go in, then we speak to and discuss with the patient. And of course, this is out of a multidisciplinary tumor board agreement as well. You can use the initial sample, but I think, obviously it's, especially if the patient has had treatment subsequently, right? The biology probably has changed, right? I mean, even from the initial testing, you don't even know how representative it is from the start, but, so it depends on the situation. For example, if you have like a recurrent, liposarcoma, right? Which you tested at the start, but then recurred again later without any treatment in between. Then maybe you can argue for a case to say, okay, maybe I can use the previous results. But if you had further treatment later on, then it's, I think, very likely that, if the patient's progressing on that treatment as well, that the biology has probably changed significantly. So I would probably want to rely on a new sample.